All right, in this video, we're going to kind of give a general overview of the cardiac cycle. Basically, what happens during the cardiac cycle. Basically, this is going to be a culmination of everything we've been covering so far, from blood flow through the heart to the EKG. Um, the amount of time that it takes for depolarization and contractions to occur, and we'll talk about some influences on the cardiac cycle as well. In fact, I mean, it's already been kind of covered anyway, because remember that your sympathetic and parasympathetic nerve fibers that innervate the heart. Remember, whenever we have increased sympathetic outflow to the heart, you'll see an increase in heart rate, and I'm just going to abbreviate this, contractility, and vice versa. When the vagus nerve is increasing its influence on the heart, you'll have a decrease in heart rate and decreased contractility, which will result in lower heart rate, lower cardiac output, and so on. So basically, if we were to define the cardiac cycle, we would say all events during one heartbeat. So everything that's happening all at once during one heartbeat. Now, I shouldn't say all at once, but all the events that are occurring during one heartbeat. So basically, the sympathetic nervous system increases the activity of all of the events during one heartbeat, and vice versa with the parasympathetic nervous system. Now, before we dive into this discussion, we have to describe the concept real quick of pressure versus volume and the type of relationship that they have with one another. Pressure and volume have what we call an inverse relationship. Inverse relationship. Basically, that means that they oppose one another. So if one goes up, the other goes down, and vice versa. Um, so, for example, if we think of a syringe, so you take a syringe, all right, and let's say we got the plunger down on the syringe. Okay, the volume in the syringe isn't very high. There's a low volume inside, so therefore there's an increased pressure. All right, vice versa, if we draw the plunger upward, pardon my art, folks, if we draw the plunger upward and we've got that syringe in a vial and we're trying to pull medication out of it, what we're doing is we are increasing the volume of the inside of that syringe. And what we're doing is we're decreasing the pressure and creating a negative vacuum and drawing in the fluid, into that syringe that we want to inject into the patient. All right. And then when you want to actually inject the medication, you place your thumb on the plunger, and then you push it downward. And then basically, as that plunger moves downward, the volume is decreasing and the pressure is increasing, and then forcing fluids out. All right. The same goes with the heart. Remember that the heart is made up of four chambers. Okay. It's made up of four chambers. All right. And let's do that. This. My goodness, that's probably the best picture I've ever drawn with this tablet. Okay. Then we've got your AV valves. Wow, that's impressive. All right. Now, so think about this with the heart. For example, remember the lower chambers of the heart, the ventricles. So think about this. When the ventricles contract, all right, when the muscle tissue of the ventricles contracts, remember the word contract means to shorten. Okay, so if we have all the muscle fibers of the myocardium shortening, then what's that going to do to the size of the ventricles? That's going to decrease their size, right? Because all these fibers are going to shorten, and then remember that the muscle tissue isn't, it kind of spirals around the ventricles. So the ventricles are not only going to shorten, they're going to twist a little bit. And if the size of the ventricles are getting smaller, we're saying their volume is decreasing. All right. And then if the volume is decreasing, then pressure is rising, and then eventually we'll generate enough pressure to pump blood out of the ventricles. All right. And then vice versa, when the ventricles relax, when the muscle cells kind of return back to their normal length, Then the ventricles get larger, all right, their size, anyways, they return back to a normal size, and then their volume increases and pressure decreases, and then that favors filling. Okay, that favors filling. So that's something to keep in mind. And we'll talk more about all these events in a little bit, but it's important to understand the concept of pressure and volume. One goes up, the other goes down. Okay. Something else I was going to say to that, but it must not have been important. So let's start diving into the cardiac cycle itself. So basically, this is something that can be described many different ways. A lot of it depends on where you want to start. Some books like to start here, basically when the heart is in a full state of relaxation. I've seen some books start at ventricular systole. I've seen some start here. The book we use for our class starts with ventricular filling, so we're gonna begin there. But realistically, you can tell the story beginning from any stage. Realistically, I think that it does make the most sense to start with ventricular filling. Anyway, but yeah, so now bear in mind though that when you take a look at this, especially when we look at ventricular systole, ventricular systole is actually kind of two parts that play into what we were just talking about, that concept of pressure and volume. All right, so remember when we have a decreased volume and an increased pressure, that's going to favor ejection, or the chambers pumping blood out of themselves. And that is the phase that we would refer to as systole. All right, remember systole, is like you hear about that with blood pressure. When taking blood pressure, the higher number when you're taking blood pressure. Remember that number is higher because the ventricles are contracting. They're forcing more blood through the vessels with more force. That's going to cause the vessels to stretch more. And then when basically when the chambers relax and their volume increases and pressure decreases, that's going to favor diastole. Okay, the filling phase of the chambers. And remember systole and diastole both apply to the atria and the ventricles because both chambers have to fill up. Now, just before we get into this, remember we need to review the fact that the atria and the ventricles never contract at the same time. All right, when the atria are in systole, okay, when the atria are in systole, the ventricles, I'm just going to abbreviate this, are in diastole. Okay, that would be counterproductive. If all four chambers contracted at the same time, blood wouldn't go anywhere. All right, there would be no flow. It would just sit there in the chambers. All right, so and then vice versa, when the ventricles are in systole, the atria are in diastole. So I mean, get used to using that lingo because next week and the week after we're going to start getting into blood vessels and hemodynamics, and these are words you're going to see a lot of again. So systole and diastole. Okay. So let's start out then talking about ventricular filling, basically how the ventricles fill with blood. So first off, the atria are going to fill up with blood, and there's a period of time when the heart is in a complete state of relaxation after the ventricles pump blood out, and during this time, the atria are filling with a lot of blood. Okay. Now, what we have to remember is we have to remember the names of the valves in between the atria and the ventricle. Remember, there are two general sets of valves. We have AV valves and semilunar. Okay. Remember, the AV stands for atrioventricular. These are the valves between the atria and the ventricle. Semilunar, these are the valves in what we call the great arteries of the heart. This would be the pulmonary valve because it's in the pulmonary artery. And this would be the aortic valve because, well, you can probably guess why it's involved with the aorta. Okay. So basically, as the atria are filling, all right, as the atria are filling with blood, eventually the atria are going to fill up with so much blood that essentially the weight of the blood is going to cause these AV valves to open up. All right, it's going to cause these AV valves to open up. And now remember, the ventricles in this situation are in diastole. I'm just going to use D for diastole. Okay, they're in diastole, so their volume is greater, and there's a low pressure situation here. So as a result, that's going to favor. Remember, diastole favors filling. All right. Now, what's interesting about this is that there's basically kind of two parts to this as well, because initially, when that weight of the blood opens up the AV valves, blood is just going to passively flow right down into the ventricles. Okay, so basically, this first part of ventricular filling is passive filling. Okay, and remember the word passive means no energy is being expended in this process. No work is being performed. All right, the valves just automatically open, and because of gravity, that blood is just pulled downward into the ventricles. And it's important to understand that 80% of ventricular filling is a passive process. Okay, so 80% of the blood that goes from the atria into the ventricles does so without any work whatsoever. All right. Now that's important because, I mean, if you think about this with people that have, there are certain people that have supraventricular arrhythmias, cardiac arrhythmias that involve the atria. Like for example, atrial fibrillation or atrial tachycardia. If the atria are beating or working erratically, a person can still live a semi to fairly normal life because we don't rely on the atria a whole lot to get blood down into the ventricles because most of the blood just does so on its own. All right, so that's actually kind of neat. Now, the remaining 20% of the blood, basically this does so, or this fills the ventricles actively. Okay, and obviously this is atrial systole. Okay, atrial systole. Now, this is a very, very important phase here because this is something that's nicknamed atrial kick. Atrial kick. Oftentimes, this is also referred to as priming the pump. Priming the pump. So basically, what I'm saying here is, so remember, 80% of the volume of the atria just falls into the ventricles on its own because of gravity. Well, eventually, the atria are going to contract, and then when they contract, remember, the muscles are going to contract, the walls are going to get smaller, and that's going to be atrial systole, and is going to force the remaining 20% of blood down into the ventricles. Now, what's important about this is the forceful movement of that blood down into the ventricles causes the walls of the ventricles to stretch out a little more. Okay, it causes the walls to stretch a little more. Now, cardiac muscle cells are very responsive to stretch. All right, so they're not like rubber bands where, when you take a rubber band and you pull on it, and you let go, it's going to recoil back to its original shape. And if you grab a rubber band and pull it even further and let go, it's going to recoil with more force because you put more pressure on that rubber band, and when the pressure is relieved, it's going to snap with greater force. The ventricles aren't like that, but the concept is similar. The more you stretch the ventricles, the harder they're going to contract. Okay, but that's because of the responsiveness of cardiac muscle cells. The more you stretch out cardiac muscle cells, basically that's going to make the contractile mechanisms respond even more, and the muscles are actually going to contract even harder. Okay, so think about how that's important then. If we stretch out the walls of the ventricles a little more than normal, then that's going to result in them contracting harder. And then when they contract harder, that means they are pumping more blood out of the heart. Okay, so that's why that atrial kick is important. All right, by stretching the ventricular walls a little bit, that primes the pump. Okay, see why we call that priming the pump. All right, because we're preparing that pump to pump even harder. All right, but that essentially is ventricular filling. And when we look at this on the EKG, so we would go here, and then all of a sudden, boink, you'd see your first wave. Okay, that would be your P wave. All right, remember that the P wave would be your SA node firing to initiate atrial systole. So that's basically what you see right here. This P wave is representing atrial systole and the firing of the AV node. Prior to this P wave, the atria were refilling with blood, and then eventually the AV valves opened and blood passively flowed down into the ventricles, and then eventually the SA node will fire, and then the atria will go into systole, hence the P wave. So essentially, when you see the P wave, you're basically looking at that atrial kick, or that remaining 20% of blood being forcefully moved down into the ventricles. Okay, and that's basically how ventricles fill. They start filling in a passive fashion, and then they do so actively. And remember that active filling, atrial systole, is priming the pump or preparing the ventricles to pump with more efficiency. Okay, so that's ventricular filling. Now, when ventricular filling is done, we're going to have something called end. I'm just going to abbreviate this: end diastolic volume, EDV. Remember, end, obviously the end of filling, diastolic, so basically we're reaching the end of when the ventricles are in a relaxed state, and obviously you know what we're saying with volume. You know, there's some kind of fluid, liquid, or gel taking up a certain amount of space. All right. So end diastolic volume. So the ventricle. So basically, what I'm saying here is that the ventricles are going to have a certain amount of blood within them. And I'm going to change the pen color because I'm not going to use red on red here. Let's go with Martian blood and green. Now, end diastolic volume in the right ventricle is going to be 120 milliliters. And same thing with the left. So both ventricles are going to have an end diastolic volume of about 120 milliliters. Okay, so they're going to be full of 120. That's going to be their volume once they're done filling. Okay, and remember, this is in a resting state. This is in a passive state. Obviously, if you're exercising and you've got more blood coming back to the heart in a more forceful fashion, that obviously those volumes are going to change a little bit. So kind of keep that in mind. Now, so basically, remember we looked at the EKG and we said that the P wave is going to be atrial systole. And then next on the EKG is the QRS complex and then the T wave. Okay, so the P wave is atrial systole. And then remember, from the P wave to the Q wave, that's what we call the PQ interval. Okay, the PQ interval. Now, what do you notice about the PQ interval? So you get PQRST. All right. Notice how it flatlines here, just for a brief, just split second here. All right, not even a full second. I mean, obviously, none of this takes place within a full second, but there's a very brief moment where there's no activity going on in the ventricles. That is basically when the SA node depolarizes the atria, okay, and then that wave of depolarization is going to work its way to the AV node, okay, the atrioventricular node. And remember remember what the AV node does. The AV node temporarily slows down that wave of depolarization. It slows things down just a little bit, okay? And remember that momentary pause again allows for just a little more filling. It allows for the ventricles to maximally fill up with blood. And then that also allows, the AV node allows for basically the appropriate rhythm of the heart to occur. So the atria are going to fully depolarize and fully undergo systole before the ventricles start undergoing this process. So that little holdup by the AV node allows the atria to fully contract and allow the ventricles to fully fill with blood. Okay. And then next, what you're going to see is the QRS complex, okay? The QRS complex. And remember in class when we talked about this, I said that the QRS complex is ventricular, I'm just going to abbreviate this, ventricular depolarization. However, there is no ejection of blood going on here. There's no actual pumping happening yet, okay? Now, that's important because after that wave of depolarization travels down the bundle of His, or the AV bundle, however you want to call it, and then travels down the bundle branches. Basically, we're going to start depolarizing the ventricles, and that wave of depolarization is going to travel down the ventricles, going to travel across the walls. That's why the QRS complex is moving in so many directions. You're seeing the ventricles depolarize essentially from all directions. Now, What's happening here? Well, first, we have to remember that when the ventricles begin contracting, they do so at the apex. Okay, they do so at the apex of the heart. Now, think about. Let's kind of pause and think about that for a second. How important that is. Okay, how important that is. The the ventricles begin contracting at their lowest point. Okay, they begin contracting at their lowest point. Think about how effective that is from a pumping perspective, because you start squeezing from the bottom and you start squeezing that blood upward. Because remember, blood that is being pumped out of the ventricles has to move, has to be pumped up into the great arteries, right, into the pulmonary trunk and into the aorta. All right, so by contracting the apex first, you're maximizing that blood being pushed upward. I mean, think of a tube of toothpaste. I mean, how annoying is it when somebody grabs a tube of toothpaste and squeezes from the middle? All right. If you want to maximize the amount of toothpaste coming out of there, you start from the bottom. Okay, you start squeezing from the bottom, and then you work your way up. Okay, and then you won't get obviously all the toothpaste out of there, but you'll get most of it out of there squeezing that way. Okay, versus if you squeeze from the middle, you push some toothpaste down and some up, but therefore you're leaving a lot in the tube itself. That'd be the same concept with the ventricles. If the ventricles contracted from the middle first, a lot of blood would be forced downward, and it'd be a lot harder to get it out. Okay. Now, the reason, remember before I said that during ventricular depolarization that there is no ejection occurring. Okay, there's no ejection occurring. So basically what the ventricles are doing during the first phase of ventricular filling during the QRS complex, this is what's called isovolumetric contraction. Iso meaning the same, volume. Okay, so basically what we're saying here are the ventricles are contracting, but their volume is remaining the same. So basically what's going on here are the ventricles are contracting and they're building up pressure. Okay, they're starting to decrease their volume and increase the pressure that they're building up with. But during this first part of ventricular systole, they're building up pressure and no blood is being moved out. Now, during this, the AV valves, the the tricuspid and the mitral valves both simultaneously close. And when they close, when they slam shut, that's when you hear that first heart sound, S1. All right. And then this is also when the papillary muscles contract. All right. And so while the ventricles are beginning their contraction, and blood is being pushed upward, blood is going to be pushed upward against the cusps of the tricuspid and mitral valves. So then as a result, when you contract these papillary muscles at the same time and you pull down, you've got blood being pushed upward, and you pull the valves down against that blood. What you're doing is you're using those two pressures to basically create a tight seal and keep those cusps closed and prevent blood from flowing backwards into the atria. Okay, so the AV valves are shut, and remember the ventricles are only. This is a building phase. The ventricles are building pressure. The semilunar valves are also closed. So basically, what the ventricles are doing, they're trying to build up enough pressure to overcome any opposing forces outside of the heart to force blood through these semilunar valves out of the heart. Okay, that's isovolumetric contraction. And like I said, on the EKG, that's going to be essentially taking place during the QRS complex. Now, the next phase then of ventricular systole is going to be ventricular ejection, when blood is actually pumped out of the heart. Okay, so remember that the AV valves, your mitral and your tricuspid valves, are still closed during this time. But now what's happened, the ventricles have contracted to the point to where they've decreased their volume and built up enough pressure to where they can overcome those opposing forces outside of the heart and actually pump blood out of themselves. Okay, actually pump blood out of themselves. So remember, blood is going to be pumped out of the semilunar valves, and the right ventricle pumps blood out through the pulmonary trunk, and the left ventricle pumps blood through the aortic valve into the aorta itself. All right, that's ventricular ejection. And on the EKG, this is seriously the best drawing I've ever done with this tablet here. We've got our P, we've got our Q, R, S, and our T waves. All right. And basically, this phase, ventricular ejection, this is happening between the S and the T wave, and what we refer to as the ST segment. The ST segment. So from the S to the T wave, that is ventricular ejection. Okay. And what else was I going to say here? Oh, and then remember that concept of end diastolic volume, EDV. So remember that the ventricles, their end diastolic volume is about 120 milliliters of blood. Each ventricle is full of about 120 milliliters of blood. In a resting heart, typically by the time that they are done pumping blood out of themselves, they would pump out about 70 milliliters. Okay, so they pump out 70 milliliters. So basically, that would, and then when they're done pumping blood out, there's going to be what's called an end systolic volume, the end of systole. So what's 120 minus 70? The heart, the ventricles are each going to have about 50 mils of blood left over within them. Okay, and basically this volume of blood that's pumped out of the heart, I should say out of the ventricles every beat. This I'm just going to abbreviate this for now. This is what we call stroke volume. Okay, that's what we call stroke volume. Remember that because we're going to revisit this when we talk about cardiac output in the next video. And then basically there's also a value that's used to describe this. There's a value called ejection fraction. So basically, stroke volume is an actual volume. Okay, it's an actual volume, 70 milliliters of blood. Ejection fraction is a percentage. Okay, it's a percentage. So about 70, 120. This is give or take about 60% of the blood that was in the ventricles is now pumped out. About 58.8, 60, round up to 60%. Okay. So ejection fraction is 60%. Now, both of these values are important because during ventricular systole, we obviously need to get the right amount of blood out of the heart. So 70 milliliters is about the right amount of blood to pump out of the heart every beat. All right, in order to get enough blood up to our lungs so we can undergo gas exchange, get rid of CO2, recollect oxygen, and vice versa, enough blood out of the ventricles so we can what was I going to say? So we can deliver oxygen to our tissues and grab CO2 from them. All right. So, and then ejection fraction, this percentage is basically, this is a good way to describe the efficiency of the heart. Obviously, the lower the ejection fraction, what we're saying here is the heart is less efficient. The ventricles are pumping less blood out of themselves, and you can probably do the math on how that's going to be bad. Okay, so that's something to keep in mind. Like I said, we're going to especially revisit stroke volume in a little bit. But that's all ventricular ejection is. All right, remember the ventricles begin contracting at their apex, and then they eventually build up enough pressure during that. They build up pressure during that first phase, isovolumetric contraction, and then eventually, once the ventricles are squeezed hard enough, they'll build up enough pressure to force blood out of the heart through the great arteries. Okay, and then that is ventricular ejection. And remember that blood that is ejected out, the volume is referred to as stroke volume, and the percentage is ejection fraction. And remember that the ventricles under normal, even under the hardest working conditions of exercise, the ventricles typically don't eject 100%. They can come close, but they don't eject 100% of blood out of themselves. There's always going to be a little bit left over. Okay. So, I mean, so you can do the math here. If you're exercising, stroke volume, ejection fraction are going to go up, and vice versa. When you're resting, they're going to go down. Okay. So that's ventricular ejection. And then during the last phase, what's called isovolumetric relaxation, or the quiescent period. Quiescent means, that's the high class way of saying quiet. Okay. Quiet. Basically, during the quiet period, this is when all four chambers of the heart are in a relaxed state. Okay, And this would begin during the T wave because the T wave represents ventricular repolarization, or the resetting or relaxation of the ventricles. So you're probably wondering, how come you don't see atrial repolarization on here? It happens after the atria contract. It occurs, but the events of depolarizing the ventricles, the QRS complex, are so great that on the EKG you just don't pick up atrial repolarization. When the ventricles are depolarized and are getting excited, it just masks or overtakes the atrial repolarization on the EKG. So you don't. That's why you don't see it. Now, during this time, remember, while the ventricles are ejecting blood out of themselves, basically ventriculars, while the ventricles are in systole, remember that the atria are in diastole. Okay, they're in diastole. So during this time, while the ventricles are, and then once we reach that ejection phase of ventricular systole, blood is going to start returning back into the atria. All right, so the atria are going to start refilling because remember, while one set of chambers are contracting, the others are relaxing. One is pumping blood, one set is filling with blood. Okay, so basically, and the atria are gonna start refilling with blood, and eventually they're gonna refill with enough blood during this quiet period, and then once they get full of enough blood, well, guess what's gonna happen? The weight of that blood is gonna force the AV valves open, and then we start over again with our passive filling, and then you just do this all over again. Okay. Um, and another thing to note here is that during this quiet period, all four valves are closed. Okay, all four valves are closed. Okay, so the semilunar valves are closed and the AV valves closed. And this is actually kind of interesting because when the ventricles return back to diastole, the little bit of remaining blood in the ascending aorta and the pulmonary trunk, well, you know how gravity works, pulls things down. That blood is going to want to go back down into the ventricles, but it's really, really cool how these semilunar valves are designed because, and you saw these when we dissected the hearts, they're cupped upward. All right, so as blood comes back down, it actually fills in these cusps of these semilunar valves, and then the weight of that blood slams them shut. Okay, the weight of that blood essentially slams them shut. And then when the semilunar valves slam shut, that's when you hear your second heart sound, or S2. So basically the dub. Okay, the first heart sound, S1, is your lub, and the second one is dub. All right. So that's something to keep in mind. And then and then the chambers, even though the atria are refilling with blood, all right, there's no volume change between the atria and the ventricles here. So there's no filling going on here, except once we get towards the very end of this phase, and then we get close to the P wave, and we have atrial systole again. Okay, but that's essentially isovolumetric relaxation. When all four chambers are relaxed, all four valves are closed, and the atria are kind of finishing up refilling with blood, and then this process is just going to start over again. And that's what the heart does on a regular basis. Okay. Now, last, let's kind of review or take a look at this. Kind of, if we look at this graphed out, this is what's called the Wiggers diagram, named after Dr. Wigger. Um, and you can look at the pressure and volume changes here. So basically, these Wiggers diagrams are typically described to show the left ventricle and left atria. But remember that the events occurring that this is going to be the same on the right side of the heart as well. The right atrium and ventricles are going to behave in a similar fashion. Um, so basically, let's see, where should we start here? So, pressure, where's atrial? There we go. Atrial pressure. So notice here notice when we look at ventricular filling, notice when atrial pressure rises, when we're undergoing atrial systole, basically when we're undergoing atrial systole, notice that ventricular volume rises just a little bit. Okay, that is that 20% of active filling. That's that atrial kick. Priming the pump. All right, and then when you look at your EKG here, notice that's when ventricular depolarization occurs, and then that's when pressure is building. And then eventually what's going to happen Remember, once pressure builds up enough from the S to the T wave, well, if we go up, notice when ventricular pressure is at its highest during the ejection phase, take a look at this. That's when the volume of the ventricles dramatically decreases. All right, and remember, end diastolic volume 120, end systolic volume 50 milliliters, and that gives us a stroke volume of 70 milliliters of blood being pumped out of the heart. Okay, but remember that the ventricles don't completely empty themselves. All right, there's a little bit of reserve left in the ventricles, and then this is going to start over again. Then you can see during this quiet period, so beginning from repolarization during the quiescent period, that the ventricles begin to refill, I'm sorry, the ventricles don't begin to refill, bonehead. That the atria are going to refill with blood, and then towards the end of this, when the tricuspid and mitral valves open up, then that's when you notice that ventricular filling is going to be at its greatest, and then you're gonna have another P wave. Atrial pressure is going to rise, atrial kick, that little bit of rise. You see the pattern here, okay? And but again, this is kind of an important graph to analyze because, like I said, this really shows you everything we've talked about is summed up right here in this graph. So this would be a good time to pause, study this, take a look at this. Compare the EKG to the pressure changes and everything that I just talked about. Because, like I said, this graph just puts together everything we just discussed. But that essentially is the cardiac cycle. And remember, just before I close this, remember the SNS and PSNS, or more specifically, the influence of the vagus nerve here. Remember that if we increase our sympathetic outflow to the heart or sympathetic nervous system activity to the heart, that is basically going to take everything that we just saw here and it's going to speed it up. It's going to speed it up because remember, the sympathetic nervous system exerts great influence over the SA node and the AV node, and then if we speed up the rate of depolarization here, then that means faster heart rate. And then you combine that with there are sympathetic fibers that also innervate the ventricular myocardium, and that's going to cause an increase in contractility or increase in the force of contractions. That's going to obviously allow for the creation of more pressure and more ejection of blood, so more pumping altogether. Whereas vice versa, if the vagus nerve, which under normal resting conditions the vagus nerve is in control of the heart, then that's gonna slow all this down and lessen the volumes and pressures of the cardiac cycle. Okay, so that basically is an overview of the cardiac cycle. The last thing that we'll talk about related to heart physiology is going to be cardiac output. Now, bear in mind, before we dive into that concept of cardiac output, remember, make sure that you have a good working knowledge of, the basics of the cardiac syncytium, the EKG, and then this cardiac cycle, because then obviously cardiac output will be a walk in the park from there.